we should make a start. Okay, so welcome everybody. We're going to get going with our prostate MRI multidisciplinary team. This has been an interesting experiment because we did this about a month ago, and we had a lot of people from Australia and New Zealand particularly, but a few others from around the world. And this time we seem to have gathered a lot more attendees around the world. In fact, we've had more than 400 registrations, and you know, we've got over 130 online at the moment, so I'm expecting plenty more to join us throughout the hour. And I can see some people tuning in from Italy and Peru, so welcome. I'd also like to particularly welcome, we've got quite a large contingent actually from South Africa and also Sri Lanka. So really hope that everybody who tunes in today finds this session useful. Now today's Prostate MRI MDM is sponsored by MRI Pro, and for the sake of full transparency, I'm actually one of the co-founders of this. This is an online training program designed to get people's experience up in reading prostate MRI. So before I introduce our very esteemed panelists, I'm just going to share my screen and just show you a very short video of what the training program looks like. So just bear with me for a moment while I do that.
Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against a radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
All right. Having seen the video, I just want to introduce our panelists. So we're very fortunate today to have Ivo Schoots, a radiologist from the Netherlands, from Erasmus University in Rotterdam. Ivo, welcome to the panel and thank you for joining us.
Thank you. It's a privilege.
We have Henk van der Poel, also from the Netherlands, who's a urologist from the Netherlands Cancer Institute in Amsterdam. Thank you so much for your time and expertise today, Henk. Yes. Looking forward to our discussion. As usual, we have Richard O'Sullivan, who's our expert prostate MRI reader, radiologist here in Melbourne. He's from Bridge Road Imaging. Thank you for joining us once again, Richard.
Hello, thank you for having me.
And Andrew Ryan is our pathologist from Tissue Path Pathology Service here in Melbourne, which specialises in uropathology and routinely provides the beautiful volumetric whole mount studies that you're going to be seeing throughout the course of tonight or today. And finally, we've got Morgan Pokorny, who's very kindly agreed to join us once again from Auckland, New Zealand, also a urologist. Thanks, Morgan.
Thanks, Jeremy.
And I'm, in case I'm unknown to you, I'm a urologist here in Melbourne as well. So just for the sake of making a point, I'd like everyone to especially note that, you know, the multidisciplinary makeup of the panel, and this is a theme we'll be returning to throughout the session today. We would like to make it as interactive as possible. Now that may be tricky because there's obviously a lot of people who are joining the session, but if you use the chat function or the Q&A function on your Zoom, then you can please just text through any questions, and where possible, we'll try and field them. And I'm sure you'll understand if we don't actually get round to your specific questions. So thanks again for everyone who's joined us. What I would like to do now is get stuck into the first case. So Richard, if you're happy to share your screen, we'll get going.
Okay, welcome. This is how we do it. Everybody's a little bit different. We do 3 plane T2A images. There's a sagittal image in the top left-hand corner, axial T2A image in the bottom left-hand corner, a coronal T2, the dynamic contrast enhanced images with color overlay here. We do an axial diffusion wave imaging, which this is the ADC in the top right-hand corner, and the high B value on the top right-hand corner. And down here on the bottom row is that we actually do a sagittal diffusion wave imaging as well. This is the ADC and the high B value diffusion imaging here. If we just, the easiest place to start is probably the anatomy, and the anatomy is best displayed perhaps on the axial T2 weight images. So we can see bladder here anteriorly, white fluid in the bladder. This is the transition zone here, which is well defined, quite heterogeneous, and the peripheral zone posteriorly. The peripheral zone has lots of different appearances, but as long as it's not a focal abnormality and it's bilateral and near symmetric, it's unlikely to be of significance. This area here, we can see these two black areas, these areas of decreased signal intensity that are bilateral and symmetrical adjacent to the base, is the central zone. We see those. If I on these images, I can co-register from the axial to the sagittal, and you'll see that it demonstrates the central zone demonstrates decreased intensity on the sagittals bilaterally and symmetrically, and on the coronals, this is the central zone here and here. It does change with age, and the bigger the prostate, the smaller the transition zone, the central zone is. The thing I use the coronals most for is for the seminal vesicles. And you can see here, this is one seminal vesicle and the other one next to it, and it comes down to a sharp point as it enters the base of the prostate, and there's no focal signal abnormality within it. If we go to the top left-hand corner, almost all the information is really on the high B value diffusion weight imaging. That is to say, the one that the urine in the bladder looks black and the abnormality looks white. If we look here, I really go through the axial high B value, and everything looks bright on that. I co-register with the area on the T2 to see if it's BPH or not BPH. So as we go through here, I can't really see a focal abnormality. This is rectal air. Rectal air is a problem for us. It gives us a local artifact. And we can see, if we go to the sagittals, we can see here, this is the rectum posteriorly. It gives us this artifact, which is why we end up having to use the diffusion imaging in two different planes. And when there's a lot of rectal air, the post-contrast images are extremely important. The post-contrast images have two different parts to them. These are the subtracted images. It's a first pass effect as the contrast goes through. You can see there's slightly asymmetric enhancement on the right peripheral zone compared to the left. If we pick up about 3 or 4 combination images of the first pass of the contrast, we call that a wash-in, and we place it over the T2 images to get this picture. So you can see that the peripheral zone does enhance bilaterally and near symmetrically, and there's no focal enhancing lesion in the transition zone.
So Richard, if I can interrupt for a second, in this particular case, this is a 51-year-old fellow who presented with really a slightly elevated PSA of 3.6, and it was another radiologist who was reading this particular prostate MRI and thought that there might have been a lesion, I think, towards the apex.
Yeah, so I think the advantage of the diffusion weight imaging, the sagittal diffusion imaging, we get a much better view of the apex. Mm. Now you can see it's really just heterogeneous. If we look at this area, maybe he was concerned about this, and that correlates to this area on the ADC, on the axial image. Mm. Now, if I draw a region of interest around that ADC comes out about 1,000, which is on the borderline whether it's normal or abnormal. So it doesn't really focally enhance with contrast. So I would call that normal.
Do you think when you go to the dynamic contrast enhancement series that might be where the if you scroll through the DCE down the bottom, whether there was
it's slightly asymmetric. It's slightly asymmetric. If you look at the subtraction image here, it's slightly asymmetric on the right apex compared to the left apex.
Now you mentioned rectal gas as being that's often a problem. And I think when you scroll back through the transverse sections of this case, it seems to be perhaps impinging a little bit. I wonder if that's an issue in this particular case or not.
It's relatively minor. This patient is now from a couple of years ago, and we didn't give patients a bowel preparation or a microlax enema. And we do that in essentially all patients now to get rid of that bowel gas, to reduce that artifact. And our recall rate has substantially reduced, and the artifact rate is also substantially reduced. But it is a problem. As we know, most of the cancers are in the peripheral zone, and you can see on these higher slices here on the ADC that I'm pointing to, that's where it impact is on the peripheral zone. So it's quite useful having the rectal preparation. What do you go about that?
Yeah, so I'd be interested to know. So obviously you're not using an endorectal coil. You can see that, and you're using a 3T machine. Just to chime in from Ivo, perhaps, is that similar to what you do, or do you guys do something different?
Oh, there are many similarities. I think Richard and I follow, first of all, international guidelines, but most important thing I would like to stress here today is that there are three main important factors that address quality in MRI, and the world is facing to a lot more MRIs with new guidelines, so we need to be aware of quality. And first of all, it's the MRI machine, and there's a lot of things to be discussed about, but a proper acquisition protocol is mandatory. And the second part that Richard touched upon is patient preparation. What you can see is if you do not give the patients a small enema or do rectal desufflation, it will hamper the images, and that will decrease the reading performances tremendously. So it's not only about discussion about the experience of the radiologist. No, it's the experiences of the radiographers, it's the patient preparation, and it's of course a good MRI machine with a good protocol and a good receiver coil. And that is very important when you go and read prostate MRIs in your practice. I think those are the three very valuable aspects that you need to address in your practice.
Yeah.
So can I ask Jeremy, if you allow me, Ivo, can I ask you a question on using the endorectal coil? I see this one is not using the coil at the moment. Is that something that is out of business now, or?
I may say that it's out of business. We have good MRI machines, we have good receiver coils, body receiver coils, and with 3 Tesla MRI machines, we recommend not to use the endorectal coil because you have definitely disadvantages like artifacts that come into play. Small air bubbles near the endorectal coil may decrease even the image quality. So endorectal coil now with a good MRI machine and good protocol is not recommended anymore.
Mm-hmm.
So we've been doing prostate MRI for well over 10 years. We've never used an endorectal coil. We used to have one. It never got out of the packet, and we use a body array coil with an anterior and posterior array, which is in Siemens talks has got 60 channels. So you need a high channel resolution coil. That's a surface coil. We never use an endorectal coil.
Richard, a couple of questions coming in from the audience, which are fairly specific, but I think they're still relevant. One is, do you only do sagittal diffusion weighted imaging if there's rectal artifact, or do you do it with every case?
Easy, every case.
Okay. Yep. And what about Buscopan? Do you give?
So we use it essentially in every case. If the patient's diabetic, we give if the patient's got glaucoma or has a past history of tachycardia, we use glucagon instead. If they're diabetic and they've got a tachycardia, we don't use anything. But we would use one of those, buscopan, in at least 80% of patients, and glucagon in 17% of patients. It's rare for us not to use it.
Interesting. Okay. What about you, Ivo? Any sort of additional medication to help with the bowel?
Yes, we also use.
You've just cut out there, Ivo. I think you've lost them altogether. Oh, they're back. You just cut out there for about 10 seconds, Ivo.
Okay, so yes, we also use buscopan. We used to use glucagon, but we stopped doing that for several reasons that are more operation-based than. Well, anyway, we stopped doing it. Yeah.
Okay. And just one more question coming in from the audience relating to B values, Richard and Ivo. So you've talked about the high B values being so critically important, but the questions are what B values do you use, both for axial and sagittal, and are they different?
For us, they're the same. The high B value is on Siemens is calculated. It's acquired at about 1,000, and it's calculated to 1,400. We do that on both the sagittal and the axials. And over the last perhaps 18 months or so, we've been using a acquired B value of 2,000 in the axial plane as well.
Okay.
Yeah.
All right. Well, we might keep moving along. This particular patient ended up having a transperineal biopsy, which is our standard method of biopsy. And in this case, because the MRI was initially reported as positive, we did target the area, and we also did template cause, and we can come back to how we do biopsies in just a moment. But Andrew, if you'd like to show the results of that.
So not a lot to show in this particular case, but certainly mainly to demonstrate that these are elongate and well-sized cores with no fragmentation, and we've got no evidence of malignancy, including the target cores with at least 3, and probably these may be fragmented, but at least 3 and probably 4 well-sized cores.
Okay. Yep. And so really that was about the end of that particular case. But just in terms of biopsy, Morgan, what's your standard in terms of doing a biopsy? Let's say the patient did, like this was initially reported, have a positive MRI. What do you do?
In terms of the technique?
Yeah.
Typically, if I've got access, I'll do a transperineal biopsy in the axial view, usually under a GA, and I'll have my computer next door so I can see the MRI images. In Brisbane, we did do a lot of MRI in-bore fusion biopsy, which is nice to have, but it consumes MRI time, and it's technically challenging to learn, but it was very reliable.
Thanks, Henk. What about you? How do you do biopsies?
We do them transperineal, Jeremy, as well, under ultrasound guidance and local anesthesia with lidocaine.
Yep. Do you follow a specific template, or do you just do targeted biopsies, or both?
Both. And the systematic biopsies are like more the octant biopsies in the different quadrants of the prostate. Yep. And I really like the transperineal. It makes doing biopsies much easier. Although it is a little bit more painful for patients, and as I understand, some are doing it under general anesthesia, but we managed to do it on the local.
Yep. And do you use any devices or accessories to help you do it under local, or just freehand?
No, it's we use a system from Varian, which is also used for the brachytherapy seat placements, and they have an app on their system to take fusion biopsies.
Okay. All right. Terrific. So let's move on to case 2 now.
Jeremy,
yeah.
So the case you showed, and maybe Richard can comment on that, it was read as a positive, right? This MRI. So, and I believe that also the central zone is just interesting to briefly touch upon. So if Richard can show up the central zone area, because that is when, in this case, it was a symmetrical compressed central zone. But it becomes difficult when it's not symmetrical. So for that purpose, you need to be aware that if you are looking at the base, at the central zone, that the false positivity can be compressed central zone by the outgrow of the transitional zone. I think that is one of the main purposes of this first case.
Mm-hmm, mm-hmm.
So just, you can see this. So just again, you can see that this is the central zone here, bilateral and symmetrical. I show it because it's much more obvious than we normally see it. It's often a little bit asymmetric, a little bit compressed, and not quite as round as this. And it is unusual to see it so clearly in all three planes. You can see it here and here. And in the sagittals, you can see there is some subtle restricted diffusion and decreasing intensity on ADC within the central zone. Sometimes the restricted diffusion is more marked than that, and so therefore it becomes more of a trap to be a pseudo-cancer, if you like.
Mm-hmm.
But I think if they're bilateral and near symmetric, I'm happy to call it central zone.
Yeah.
Absolutely. Yeah. Okay. Thank you.
All right, Richard, are you happy while you're screen sharing to perhaps get up case 2? This is now a 67-year-old man who presents with a PSA of 7.4.
Okay. So it's, again, it's a relatively small volume prostate, only 15 cc. He's moved just a little bit. If we look on the axial T2s, everything looks a bit dark. Most of the peripheral zone is much darker than we normally expect it to see. It's all near homogeneously decreased signal intensity with some whirling in the transition zone, typical transition zone appearance. If we go,
Richard, could you zoom in a little bit, because we have an 8-panel view and maybe some participants will only look at small laptops. Yes, great. A little bit more if possible. That is better. Thank you. Yeah.
So we can see the mixtures of hyper intensity and low signal intensity. Most nodules are typically better defined on the margin than they are on here, but there's no focal homogeneous area of decreased signal intensity. And we see this patchy decreasing intensity. This is near symmetric in the peripheral zone. If we go to the high B value diffusion wave imaging, there is some asymmetric restricted diffusion in the transition zone. It's much more marked on the right than the left. And there's no other real abnormality in the peripheral zone. If we look at that again on the sagittals, we can see here it's not all that convincing, but there's definitely some asymmetric restricted diffusion. If we go to the colour, we can see if the picture I'll mag up, you can see it's markedly asymmetric in the contrast enhancement, much more marked on the right than the left.
When you say colour, Richard, which is what we're looking at the moment.
This is the DCE. We use what's called the wash-in phase, and we've colorized the contrast enhancement, and we've overlaid it onto a T2A images, T2A to give us anatomical localization. So I just abbreviate that to the color, or it's also called the DCE. Yep. If we look at the subtraction version of that, we can see here, this is focally enhancement. So when we see asymmetric restricted diffusion and focal contrast enhancement in the transition zone, we could argue about whether this would be a PIRADS 3 or a PIRADS 4, but this patient needs to be biopsied there.
So this is an interesting one. This is kind of the reverse of our last case, because the original report on this one, and obviously we're deliberately throwing in some curly MRIs, it was actually negative. It sort of really throws up a couple of issues, one of which, of course, is, as you've alluded to, is this blush on the dynamic contrast enhancement. But as you said, not a whole lot to see on the other series.
Well, this is kind of anti-PIRADS a bit, because it doesn't really fit into the scheme. And it's really my adaptation as a result of seeing PET. And you'll see in PET, the ones that are often missed on MR are focally enhancing lesions, which are not that obvious in most of the other series. So I've actually changed my mind about focal contrast enhancement in both the transition zone and the peripheral zone, and it makes me much more concerned than I was before we did a lot of PET. What do you think about that, Ivo?
Yeah, well, there's worldwide a big discussion going on. What is the added value of contrast enhancement? And it's a difficult discussion, because what we all understand is that the majority of cases, you do not need contrast enhancement for the final reading, your final judgment. Some lesions are very large that you even, well, feel it, and you would not need an MRI. So for sure, those cases, you don't need contrast, just for the identification and the characterization. But there are some cases that you will not see on your T2 weighted images and on your ADC and DWI. So for those reasons, if you do not use contrast in your practice, you will miss, right? And then there's a third reason, because it gives the reader some confidence. It will definitely give extra confidence to call an MRI positive or an MRI negative. So that's a third major aspect of using contrast. There are many reasons not to use contrast, of course, as well. So you need to balance, in fact, for each patient, whether you should use contrast or not. And this is a difficult discussion. But the main point that I would like to make is that contrast has added value. If you start abandoning contrast from your practice, you need to have some kind of a patient recall system for patients that you are in doubt with, whether you cannot make the diagnosis on MRI very carefully. So you need to recall those patients, or even you should do on-table monitoring. But that is, of course, a lot of logistical issues. But you need to have some kind of a safety net to make a lesion more positive or more negative. And I think that is the added value of DCE, also in PIRADS classification.
So Ivo, just on that, in terms of PIRADS classification, is now a good time for us to perhaps quickly go through that diagram?
Yes,
in which case I'll just get it up and I'll let you take us through it. Richard, yeah, there we go. All right, so just bear with me for a moment. I'll just share my screen.
Just while that's coming up, we use this, we use contrast in every patient unless they've got a contrast allergy.
Here we are. So hopefully that, can you see that, Ivo?
Yeah, I can see it clearly.
Happy to take us through that reasonably quickly.
Yeah, so first of all, Richard showed the second case that there is a lesion. So first you need to identify a lesion, yes or no. And then the second step is, where is it located? Because location is important to final judge the lesion on a score of 1 to 5. And we use the PIRADS score. And the PIRADS score, the PIRADS classification is actually the international, worldwide accepted classification system for reading prostate MRI. And that is because it has definitions for each score. What you see here in the upper area of this image is the diagram of the prostate, and in yellow is the transitional zone, and in, let's say, purple, it's a peripheral zone. So be aware, if you see a lesion, locate it. And for this second case, what is difficult is to see whether this lesion is in the transitional zone or in the peripheral zone. And why it is important. If it's in the peripheral zone and you are in doubt, it's not a clear MRI negative, so we score it 1 or 2. And if it's a clear MRI positive lesion, we score it a 4 or even a 5 if it is larger than 50 millimeter. But if you are in doubt, you say it's a score 3 with its definitions, of course. So when a lesion is located in the peripheral zone, contrast has its additional value in upgrading a score 3 into a PIRATS 4. Yeah, thank you, Jeremy, for pointing that out. So in the PIRATS classification, the added value for scoring the lesion is only in the peripheral zone, right? So a lesion enhancement in the peripheral zone will upgrade a equivocal case, an indeterminate case, into a PIRATS 4. And why is that important, whether it's a PIRATS 3 or a PIRATS 4? It has everything to do with risk assessment. So if you discuss with, of course, your urologist or your team in your MDT, then of course, we may say, well, if it's a PIRATS 3 and it's not a very high risk patient, you may consider not to biopsy and put this man on a surveillance strategy, for example. But if it's a PIRATS 4, the risk of this lesion is more likely to have clinically significant cancer. So that is why it's important to localize and to score or classify this lesion appropriate.
Just to interrupt you for a second there, Ivo, thank you, this is fantastic. But Henk, Ivo makes an interesting point about, you know, comparing PIRATS 3 to PIRATS 4. In your practice, will you always biopsy a PIRATS 3, or will there be cases, as Ivo suggested, where you may elect not to?
Yeah, there definitely is, Jeremy. I think clinical practice is kind of resilient to all the scores that we clinically have, like PIRATS. The patient is important, the age of the patient. We haven't discussed DRE, but we feel that is essential as well. So if the DRE is positive, even in a PIRATS 3, I would do a biopsy. Even a PIRATS 2, I would do a biopsy. So we shouldn't forget about that. That is still the indication. An older man with small PIRATS 3 lesions and larger prostates and moderately high PSA, we may not take a biopsy, and we may follow that patient initially. Indeed, that is one of the strategies that we follow. Is that answering your question?
Absolutely perfect. Yep. Thank you. Sorry to interrupt, Ivo. Carry on.
So if the lesion is located in the transitional zone, the role of contrast is not there in the PIRATS classification anymore. And one of the reasons is that we have in the transitional zone so many benign BPH nodules that are really focally enhancing tremendously. So focal enhancements of a BPH nodule is of course not a malignant sign. So therefore contrast is not of added value in a transitional zone. In fact, the dominant sequence, and I forgot to tell you about the peripheral zone, but I will come back to that later. The dominant sequence in a transitional zone is not the high B value or the ADC, it's the T2 weighted images. And that is also because of all these BPH nodules have very, maybe Ryan can, or Andrew can comment on that, has a very, how you said it, stroma that is very condensed. And that is what we see, of course, on our MRI. It's the phenotype of very dense tissue. So therefore, diffusion restriction or our DWI sequence is not of that much value, and finally call it a malignant lesion. And then morphological characteristics on the T2 weighted images become very important. Whether it's circumscribed, whether it's homogeneous low signal, it has a lenticular shape. Those aspects become very important in the transitional zone. So if you start reading prostate MRI, really understand the morphology of malignant lesions, read the definitions, because that becomes very important in the transitional zone.
Thanks. Thanks, Ivo. That's terrific. I'll stop sharing that diagram now so that we can just carry on with this case, because we've been saving up the big guns of pathology.
Can I just say one thing about this case before we look at the CAT?
Yeah.
So this is a hard case, and the transition zone looks a bit different to normal. And this lesion demonstrates focal contrast enhancement in the transit.
Yep.
This lesion demonstrates focal contrast enhancement in the transition zone, not in the peripheral zone. That's what I was saying. It's anti-PIRADS. And that's where I've changed, and I'm outside of PIRADS now by saying focal enhancing lesion in the transition zone. To me, that brings up to a PIRADS 3 from PIRADS 2. So that's against what PIRADS says.
Yes, but this is where Henk's comments before, I think, are very relevant, because there's another factor at play here, regardless of the equivocation about the MRI, and that is this guy's prostate's pretty small, right? And he's got a PSA of 7.4. In fact, the prostate volume was measured at only 15 cc's. So when it was initially reported as negative, myself as a urologist was actually very suspicious that, you know, maybe we are missing something here. And even though if you were going to be very strictly reporting according to PIRADS, you may not have said it was positive. Because of that blush on the DCE, we did go ahead and do a biopsy, and that included some targeting of that lesion. So Andrew Ryan's got that biopsy result.
Okay, sorry, this is, so that's the right anterior, and the left posterior have tumour foci. Including that right anterior, that must have been the target area that you're talking about, 3 + 4, 20%. So there are individual glands here, but there are also, it's a bit hard to see on this stain, but there's also more complex structures within this area here. So that's graded as 3 + 4, 20%, up to 5 millimetres.
So given that he had a positive biopsy, he did go on and have a radical prostatectomy. Andrew, do you want to show us how you present that?
Yeah, so look, this is just another little side track similar to the PIRADS, and this was just to put a bit of clarity on some of the volumetric pictures that you'll see attributed both on these cases and on MRI Pro if you were to use that. This is the macroscopic of a radical prostatectomy that we receive. We ink it, and then we cut the specimen according to a diagram such as this, where we take serial transverse sections perpendicular to the prostatic urethra, and then additional parasagittal sections of the apex and the base, and they're laid out. And so this is what we see at the cut-up bench. And then these transverse sections are additionally cut into quadrants, so we don't use hole mounts. Some places use hole mounts. They tend to make the fixation of the specimen take an additional amount of time, and our urologists like speedy reports, not big hole mount slides. So we've gone down the quadrant processing. From there, what we end up is with these quadrants on a slide. And so when we report the slide, we actually mark on the slide where the tumour is with Texta. And we outline it under the microscope, that is. Not, you know, you're seeing this here as a macroscopic slide, but we actually mark it as we're looking at the microscope. From there, going back to that additional picture, we then reconstruct those slides such that we get a volumetric picture. You may see the little cuts across these transverse sections, and they're the slides reconstructed. So then there's a diagrammatic representation of the index tumour, which is usually marked in orange for us, and then other foci are marked as black. And we also mark areas of extraprostatic extension, seminal vesicle, in blue. These are our legends up here, and positive surgical margins. And you know, the feedback we get, we've been doing this now for 15 years, the feedback we get from the urologist is this becomes very helpful for both them for a 3D spatial kind of idea of the actual specimen, as well as demonstrating to the patients the extensive disease and other factors.
Yeah, I couldn't agree more with that last comment, Andrew. I mean, as you said, we've been doing, or you've been doing this for several years now, and the the multidisciplinary meeting that we have been running since 2014 has really been predicated actually on the ability of your pathology to be able to provide this feedback, because this is, to my mind, the ultimate way of learning where you've gone right and where you've gone wrong with your MRI reporting. So for any radiologists and in fact urologists listening out there today, I think if there is a chance that you can convince your pathologist to provide this, if you want to really get good at and quick at learning how to read prostate MRI, I think this is we're very, very fortunate to have this service.
I think when you say about where you go right, where you go wrong, also I think that the other element that we've really found is where the limitations are. Where to draw the line on where the limitation is on what you can and you can't see, and that it obviously is false positives, false negatives, those kind of things, but also size of tumour and invisible tumours, what they look like.
Yeah.
Addressing that issue, I mean, the tumor that you visualize on these images is much larger than the area that was identified as suspicious as on MRI, right? That is,
yeah, that's in general. That's not this particular case. This is not case 2. This was just a demonstration. So I can show now his radical if you wanted to go to that.
Please, that'd be good.
So this is the actual real case that we saw of the MRI, and that does correlate very cleanly with the area that Richard on the right-hand side. There's a definite transition zone focus, which was designated as the index focus, and then these other foci that are marked in black, so down towards the left apex and also in the right peripheral zone as well.
And Andrew, you flipped that left to right, obviously deliberately, because...
Yeah, so these are a little bit earlier. We, as I said, we've been doing this for 15 years, and we used to have right on right, and so right on, as an anatomical specimen rather than an MRI. So we've flipped those around, and I've done that for this case just because we didn't used to do that, but we now demonstrate them as MRI type images. You'll see that, I think, in another one. So this, when I said before, we do it into quadrants if the prostate's small enough, and as you mentioned, Jeremy, he had a very small prostate. So this is the whole of the right lobe, and you can see the outline of the actual tumour that we saw on the volumetric, and that's got areas of both pattern 3 with these well-formed glands, as well as more complex and fused glands here. So a definite component of pattern 4. Also shows histologically that denser stroma around the outside. So this is part of the transition zone that doesn't have much in the way of glands, but that's just a side note. So interestingly, that's the PSMA stain. We did an immunohistochemical stain as well. We're not going to go through that at the moment, but it does show the demonstration of the density of the tumour quite nicely, and that's tumour and benign gland staining, but there's a much denser area of tumour staining in that area. So in summary, the actual tumour, as we've shown on the volume map, was 3+4, 30% in that right anterior transition zone corresponding to the MRI lesion, and then some additional foci, 3+3 and 3+4 in the right peripheral zone and left apex, and they were all organ confined and margins clear.
Yeah. Thanks, Andrew.
And is there a logical explanation for you by analyzing this radical prostatectomy specimen, why some areas have more enhancement on MRI than others?
Is that to me or Jeremy, or?
A question for Richard, perhaps, or?
Yeah. Are you talking about tumours or areas of prostate in general?
I was just in general, why some foci has really focal contrast enhancement, whether others do not have. So in this particular case, the tumor is larger than what we see on MRI, especially larger than the contrast, than the focal enhancement by contrast. So I was just wondering whether you as a pathologist say, aha, but this is the underlying histopathological phenotype, why we see contrast enhancement on our MRIs.
Well, we have this discussion quite regularly at the meeting. My theory is that it's just the cellular density. The cellular density of these. So as like it also, we talk about invisible 3+3 lesions as well, where the density of the glands are actually more similar to benign glands Whereas the higher grade tumours, which we know are actually more visible on MRI, become a lot more, the cellular density per unit measurement is much higher.
I think that's definitely true with T2 at the diffusion. That's what we're looking at is cell density. But on the post-contrast, I presume it's got more blood vessels, but we don't see that on the PET. That's true, isn't it, Andrew?
Yeah, but that's certainly not a factor that we look for. But you're probably right. Sorry, I was talking in general, but you're talking specifically about the contrast. Yeah, look, that would make sense. But the higher the density of cells, presumably the more vessels as well. That would certainly make sense.
Now, thanks guys. I can see time's ticking away from us. So I do want to at least just get one more case in, because this next one throws up a whole lot of other issues. So Richard, if you're happy to just pop up case number 3, and I'll start to introduce it, because we've actually got a couple of sets of imaging on this particular patient. So this is another young fellow, 57 years of age, who initially presented with a PSA of 13. And perhaps Richard, as you've...
So you can see that screen now?
Yeah, if there's a chance maybe of reducing the number of images on the screen, just so that it can be a little bit bigger, that might be easier for the...
So let's just start with the sagittal T2s. You can see this is quite a small gland. I've got it measured at 25 cc. If we go to the axial T2s, we're going from base with the bladder here towards the apex, and you can see there's really extensive decrease in intensity, predominantly in the peripheral zone, but also extending into the transition zone, occupying most of the right half of the prostate, but definitely crossing the midline here. This is what a normal capsule looks like, and you can see here this capsule is irregular with an extracapsular mass through here. It's actually unusual for us to see such extensive extracapsular mass. If we then go to the more superior level, this is the seminal vesicles should contain fluid here, but you can see they contain focal decreased signal intensity on T2 images. So I think that's bilateral seminal vesicle invasion. If we just go to the coronals, remember I showed on the previous case, we should see these coming down as a sharp finger into the base of the prostate, and all of this area of decreasing intensity is seminal vesicle invasion into both seminal vesicles. If we go to the ADC, you can see that it is decreasing intensity on ADC corresponding to the abnormality on T2 imaging, but it's actually not that dark. So sometimes very high-grade tumours are actually not that dense, and the ADC value is not as low as we would think it would be. This will be a very high-grade lesion based on its other morphology. And if we look on the high B value, you can see it's obviously high B value, increasing intensity in high B value corresponding to the ADC and the T2. Just to finish it off, we look at the sagittals, again, very bright through here, and we don't really appreciate, most times seminal vesicle invasion, you will see on the sagittals, you'll see it go bright on the high B value within the seminal vesicle, which is not so convincing on that, but is extremely convincing on the T2s. You can see here, focal decrease intensity completely replacing the seminal vesicles. Mm. Everything enhances. If we go to, you can see here, it's asymmetric. It's not as compelling as the other sequences though, but you can see here the seminal vesicles both enhance. So I think this is an extensive PIRADS 5 lesion, base to apex, much more extensive on the right than the left, extracapsular extension, bilateral seminal vesicle invasion.
Okay, so it's obviously based on that report, Richard, it's very likely that we're dealing with some pretty aggressive cancer here. Henk, we're going to come to the pathology in a minute, but I wanted to ask you not so much about diagnosis here, which we can see is going to be pretty obvious probably, but given what you've seen on that image, how does what you see on an MRI affect your decision-making regarding nerve sparing, for example, if you do go ahead and do a radical prostatectomy?
Yeah, Jeremy, it's good points. I think there's more on MRI than just a tumor. There is a lot of anatomy. It was in the first presentation clearly stated. I love the MRI because it gives me anatomical information that guides me towards the prostate and the surroundings. So we measure several things to decide on how to proceed with surgery or do surgery at all. And the first one you say nerve sparing, but to me that's number two. The first one is continence, urinary continence. So if I'm not mistaken, I read the MRI, there is no ingrowth into the urethra, into the apex of the prostate extensively. So that will be one of my prerequisites to go for prostatectomy. Then what I do measure is the membranous urethral length. And well, you may be able to show that, but I think most people know what I mean. It's the distance between the corpora of the penis and the apex of the prostate. That should be of a specific length in order to make sure the patient has a fair chance of becoming continent.
So we know, sorry, Henk. Yeah. So membranous urethra, we know that is a stratifying mechanism for risk of incontinence post-op. Is that something you do routinely measure on MRI?
Yes, we do. And I was just looking at Ivo again because we have some. Well, we are studying. There is a lot of literature on the value, but the exact way of measuring has not been determined, and we're working on that at the moment. I think it is important to measure it correctly, and the literature states if it is below 12 millimeters. That is the median of the values, then your risk of becoming incontinent after prostatectomy increases. So I have two options for men with a small membranous urethral length. Either I do not do surgery, or what I now started to do for a year about is the radius sparing approach. And I was really amazed how that improved my early continence of the patients, even with a short membranous urethral length. So remember, membranous urethral length has only been predictive in the retropubic approach, not in the radius sparing.
Right. Interesting.
So in this picture then, would you measure from here to here?
Yes, well, maybe it goes beyond this this scope of this session. Yes, it's the border of the apex of the prostatic tissue until the bulbus of the penis. So, and yeah, that may vary quite some millimeters, right over there. Yeah.
To be honest, Jeremy, and to answer in a non-academic way, I hate it, but it is often in clinical practice the way it goes. I consider this guy having a short mo, just by the experience and the number of MRIs we were shown by Ivo. So in that case, I would be reluctant, not so much for the nerve sparing to your first question. I think we shouldn't do nerve sparing on this guy on the right side. That's clear for me. What I think is more important to know whether there is still a rectal plane, whether there's still fat in between the prostate and the rectum. So I like that information in the report from the MRI as well. I'm also not too worried about the invasion in the seminal vesicles. I don't know for you, Jeremy, but I think we can take that away. The issue comes when it is growing into the trigonum of the bladder. Then it is much more difficult. So I like that information as well for deciding on whether to go for surgery or not. Yeah.
Yep, totally agree. Morgan, any additional comments from you in that regard, in terms of planning surgery?
Yeah, look, so I really, like Henk commented, I really do value the MRI. I missed his last few comments because the connection faded, but one of my little rules of thumb is if the apex of the prostate is at or below the inferior margin of the pubic symphysis, which you often see in obese patients or otherwise just really tall, heavy men who might not be carrying a big stomach, it usually means that anastomosis is going to be very difficult robotically and probably impossible if you're doing an open operation. And then I've seen a couple of patients where they've had quite clear urethral invasion, which is only visible on the ADC and not on the T2. And I've sent those for radiation because the chance of positive margins is almost 100%. The question is, how often have you seen quite obvious ADC changes in the urethra below the apex that would make you suspicious for tumor growing down the urethra?
That's a very good point. And actually those questions pop up in those interdisciplinary discussions, right? At first, I never looked at it, for sure. But the question from the urologist made me aware of that area.
I've had two patients, one similar to this volume of tumor, PSA 70, 4+3. He went on hormones for a year before deciding if he'd have radiation or surgery. No mets on PSA at the second MRI and PSMA. And all the changes in the urethra resolved after a year on hormones. But I still sent him for radiation because I was just worried that there'd be little foci of tumor left in his urethra. But I've had two cases in it, and for me, MRI really helped in those situations.
So as you can imagine, in this particular case, with that MRI appearance, we went on and did a biopsy. So Andrew, if you're happy to show us what we found.
I'll just get Richard to hand over. Oh, there we go. Okay. So that's his biopsy results. Extensive, up to 4+4 pattern disease in all core sites, up to 15 millimeters in multiple sites, and evidence of intraductal type growth and extraprostatic extension within the cores.
So,
if I could just say something, this is a high-grade tumour, and the ADC is not that low.
Yep.
So a lot of the original literature would say the lower the ADC, the higher the grade, which is true most of the time, but not all the time.
Is there any relationship with intraductal in regard to that, do you think, Andrew?
I couldn't, no, I'm not sure, Jeremy.
Yeah, no, fair enough. Just while we've got that biopsy up, you can see there that there's perineural invasion on the biopsy. Is there anything that you would comment on about that? What does that mean when you see that on a biopsy, Andrew?
Look, it just usually, the nerves that we see microscopically are usually peripheral, so there's a bit of an inference that it's extending close to capsule. It's certainly associated as a prognostic feature on biopsy, and we're required to mention it.
And when you see extraprostatic extension on biopsy, does that typically translate to extraprostatic extension on radical?
It always does, because we're quite conservative in regard to calling extraprostatic extension. I really need to see tumour in fat and properly in fat, not just a couple of fat lobules here or there before I call that.
Yep. So just to speed through the rest of this case a little bit, this patient then had staging, and certainly in our practice, we're routinely using PSMA PET for staging of higher grade cancers. Now, obviously there's some debate about whether that's standard of care or not, certainly not yet in standard of care from a guidelines point of view, but something that we've had a lot of experience with in Australia for the last few years. And I will tell you for the sake of time that his PSMA PET showed a very avid primary in the prostate in exactly the same spot as the MRI, as you might expect, but no evidence of metastatic disease at all. We can discuss PSMA PET perhaps on another occasion. So he went ahead and I did an open radical prostatectomy with a pelvic lymph node dissection.
So again, this is another one of the flipped ones. So this is March 2016, hence the flipped nature of it. So right-hand side on the left-hand side in the picture, and really quite extensive tumour right from apex all the way to base, predominantly on the right-hand side, but also quite prominent extension into the left lobe as well. And as I described, the legend up here, there's extensive extraprostatic extension, particularly on that right-hand side, and also bilateral seminal vesicle invasion. Just histologically, this is a very dense tumour, a lot of effused glands. And in the next picture, this is what we describe as intraductal. You can see a very compressed rim of tumour cells around the outside with dense cribriform areas, also areas of necrosis here within intraductal, the intraductal component. And then you mentioned about the PSMA being negative. I've taken this picture here. There was a single periprostatic node, and we see incidental periprostatic nodes, not infrequently within the extraprostatic tissue that's taken. You can see how the proximity of it to the actual prostatic tissue there, and there was tumour involvement of that, but no tumour involvement of the other nodes that you took. And I think we ended up with 15 odd regional nodes. So in summary, this is graded as a 4+3, 80% overall, and that's partly because the whole thing was regarded as the index tumour. So there was other pattern 3, no pattern 5 there because the necrosis that you saw, until very recently at a consensus conference, we haven't been including the necrosis within intraductal as a part of the grading. So that's why you might question why there was no pattern 5 there, but extensive extraprostatic extension, seminal vesicle involvement, and the single periprostatic node.
Okay, so in terms of this guy's actual history, 6 weeks post-op, which is when we routinely do our first post-op PSA, his PSA was 0.01. So essentially undetectable, but there was no less than sign in front of it. And then 9 months post-op, 0.36 was his PSA. Now, we then actually got a further PSMA PET at that stage, which again, negative. But we also did a prostate MRI. And I think, Richard, you may have that.
Can you see that? So this is the sagittal T2s, typical appearance of a post-prostatectomy. Here is the anastomosis here, rectum behind, bladder here. No obvious mass on the T2. If we look on the axial T2 images, bladder here as we go down, this is a post-op appearance to the seminal vesicles. It's just an irregular black line. And as we go down to the anastomosis itself, I can't really see a mass. There's nothing there that demonstrates restricted diffusion. In the bottom right-hand corner, I'll just mag that up. You can see, however, there's focal contrast enhancement over about 3 centimetres. This is a very obvious midline anastomotic local recurrence. If we go to the this is the subtraction image. As you can see here, there's extensive contrast enhancement throughout the midline. So it's really placed right at and anterior to the anastomosis. The MR is much better for the midline anastomotic recurrence than PET. The lateral seminal vesicle bed or pedicle anastomosis, MR and PET are about the same.
So it's interesting because we do have guidelines now suggesting if PSMA PET is available, if the PSA is greater than 0.2, as it was in this case, that it is reasonable to get that. Now, sometimes it'll be positive, sometimes it won't, but I just thought it was worth just bringing up the fact that sometimes MRI can be pretty useful in this situation as well. Ivo, do you have any comments about the use of prostate MRI in the post-radical prostatectomy context?
No specific additionals to Richard, but we also see, so previously we really focused on contrast enhancement, but also the DWI sequence with ADC low signal intensities may help to identify local recurrences, and that's from recent publications with, of course, correlation studies with the PSMA PET CT. So what are the MRI image characteristics? So yes, contrast enhancement, but also the DWI may play a role in identification. So those two images, same for detection, also play an important role in recurrence identification.
Henk, have you got any views on this, or do you have any experience with PSMA PET?
Yeah, Jeremy, we do PSMA PET when the PSA after prostatectomy rises over 0.2.
Yep.
I like this case very much. We have many of these cases. Then we become pragmatic to some extent as well, because if the PSMA PET, like in this case, would be negative, we would go for salvage radiotherapy anyway. So practically, what is the benefit? And my question to you is, how did you treat a patient? Did you take a biopsy of the lesion to confirm the presence of the tumor? Because the MRI is impressive.
Yeah. So look, we didn't. We trusted the MRI, and the patient did have salvage radiotherapy. And so before he actually received the salvage radiotherapy, his PSA got as high as 0.75. After salvage radiation, it went down to 0.11. But then another couple of years have passed, so very slowly, but it has started to creep up again. So we obviously haven't cured him, and he's got further disease. Yeah. Now, I can see that we are past 8:30 Melbourne time, which means that we're past 12:30 Netherlands time. So I would like to draw the session to a close, but obviously before I do, I very much want to thank all of our panelists for joining us tonight, particularly our special guests from the Netherlands, Ivo and Henk. Thank you so much for taking time out of the middle of your clinical day to join us, and I really hope that all of the attendees appreciate that. And of course, thanks to our usual panelists, Andrew, Richard and Morgan. Really appreciate you also taking the time out for this session. But I would also like to thank all of you out there as attendees for taking your time to learn about prostate MRI, because I must say I think that learning how to read prostate MRI is possibly one of the most important things we can do in terms of improving the accuracy of diagnosis of prostate cancer, minimizing misdiagnosis, minimizing biopsies that are unnecessary. So thank you for making the effort to join us with this session today. Now, if you do want to go away and practice your new skills, you can access the 300 cases that we talked about at the very beginning of the session, and that's on MRI Pro. And you can see, hopefully you may be able to see the website there. It's just mripro.io. And if you subscribe, then you can get access to 300 cases, and you'll see that all of the positive ones have those beautiful pathology verification that we've seen on the session tonight. Just another thing I wanted to highlight to any of the users out there, also on the website, we've got a brand new quiz of just 5 cases, so you can actually test yourself against other radiologists and urologists around the world. So again, if you just go to the website, you'll find at the top the quiz section. We will be sending out a survey following this session, so if you have time, please feel free to fill it out and send it back to us, because we do want your feedback. We want to know how we can further improve various aspects of this session for future relevance, so thank you. And please remember that we're going to be recording the session so that we can post it online, so that for all of you who weren't able to attend today, if you've missed it, or if you think it was worthwhile and you want to tell your colleagues about it, please go to the website once again, and you'll see that we have posted the recording. So you can catch it there, and you can even speed us up if you haven't got time. You can put it on double time if you like. So look, we'll keep you all posted with any details of any further installments. Thank you all once again. And if you do have any questions, just one final thing, if you have any unresolved questions from the discussion tonight, feel free to email us at support@mripro.io. Again, I can't promise that we'll field every question if there's lots coming in, but we'll certainly do our hardest to do that for you. Thanks again, everybody. Thanks, Henk and Ivo especially, and I'll let you get on with the rest of your days.
Thanks.